So I'm with the Pain and Policy Studies Group. We're an organization on campus. We are a division within the Carbone Cancer Center at the School of Medicine and Public Health. We work on improving access to opioid medications globally as well as domestically in accordance with the Single Convention on Narcotic Drugs. And I'm probably going to just throw a lot of terms out at a lot of you, and you're not going to understand them, so just bear with me because I'll explain things as we go along. Our organization is a World Health Organization collaborating center for pain policy and palliative care. That basically means that we undertake efforts on behalf of the WHO and at the direction of the WHO in order to promote their goals in these areas. So a few key terms before we really get into the meat of everything. When most people think of opioids, they think of one opioid in particular, and they think of heroin. And that is not the only opioid. That's an example of an illicit opioid. Many people don't actually know this, but heroin was initially created as a medicine. And it is still used in, I think, the UK. I don't know if it's used anywhere else, and it's not used very often in the UK. But it is still used as a medication. I believe that the medical term for it is diamorphine. But an opioid is basically just a natural or synthetic drug whose pharmacological effects are centered on certain receptors within the brain. So it could be a natural opioid such as morphine, or it can be synthetic like methadone. A convention is just another fancy word for a treaty. Availability and accessibility are the two areas that we work on in relation to opioid medications. They differ very slightly, and oftentimes they're used interchangeably, but they're really not one and the same. Availability is when an opioid medication is actually present within a country. So if there's stocks of morphine at a hospital. Accessibility is if patients are actually getting the medication. So if doctors are prescribing it, if the laws allow pharmacies to dispense it. Palliative care, as defined by the WHO, is an approach that attempts to improve the quality of life for patients who are facing life-threatening illnesses. And this includes pain management, as well as addressing physical, psychosocial, and spiritual side effects of the illness. And then diversion is taking a illicit drug and moving it into an illicit channel. So when you hear on the news about people stealing oxycodone from a pharmacy, that is an example of diversion. They're taking it out of the legal market for the drug, which is the pharmacy, and then moving it to being sold on the streets. And then morphine and methadone are two of the most commonly known opioids that are dealt with. Morphine is actually an essential medicine as defined by the WHO, which means that hospitals should stock it, doctors should prescribe it. It's a necessary medication for treating pain. Methadone is also an essential medicine. It's used for treating drug addiction. So people who are addicted to heroin, it attaches to a receptor in their brain and it gives them this euphoric feeling. What methadone does is it attaches to that same receptor in the brain, but it doesn't give the euphoric feeling. So people who use methadone in a controlled environment then can function throughout their day and actually wean themselves off of heroin without feeling the withdrawal effects, and therefore they can work on the other factors that go into addiction, such as the social factors and spiritual factors that may accompany it. So there are 5.5 million terminal cancer patients in the world. There's 1 million end-stage HIV and AIDS patients as well, and all of those patients require pain management. Unfortunately, what we see here is that most of the world doesn't have access to pain management. 85% of the world's population has no access to pain medications. And when I'm saying pain medications, I'm referring to opioids, just kind of shorthand that I'm going to be using. Most of the opioid medications in the world are used by rich Western countries such as the United States, Canada, the United Kingdom, other countries in Europe. Very little is used by countries in Asia, Africa. Australia also has a good consumption rate. And as I mentioned before, morphine is an essential medicine, yet it's still not accessible in most of the world. So one of the reasons that these drugs aren't available is because of very strict policies and practices within the countries. A lot of governments are afraid of addiction to these drugs, and we'll get into that a little more in a little bit, but that impedes access. So what we do in our office is we work on helping to spread the balance in policies around the world. The Single Convention on Narcotic Drugs was passed in 1961, and nearly every country in the world is a signatory to the Single Convention. The only countries that aren't signed on are basically countries that are too small to abide by the terms of the convention, such as Vanuatu, little microstates in basically the South Pacific. So the principle of balance comes out of the preamble of the Single Convention, which actually says that narcotic drugs, and in this case, narcotic drugs is a legal term, so don't think about 21 Jump Street where you have narcs who are trying to get whatever drugs off the street. That's not what we're talking about here. Narcotics refers to drugs that literally induce a sleepy state, so that lead to narcomania or sleepiness. But that has come to mean legally opioids and the like. So the Single Convention came into being to basically replace a bunch of other treaties that countries had signed, and not every country signed every treaty, and countries had agreements with other countries about importation and exportation and taxing. So this came to kind of get rid of all of that and give the whole world a unified stance on how to deal with these drugs. The preamble of the Single Convention acknowledges that the drugs are dangerous, that there is an abuse potential, but that they're important and that there are very good uses for these drugs, that we can treat pain and end suffering using these drugs when they're used correctly and in the right populations. And that basically is the principle of balance, that we want to allow for access to these medications while still controlling them and limiting abuse and diversion. Many of the high-level international organizations have supported this. The CND is the Commission on Narcotic Drugs. They meet every year to discuss the treaty and things going on in the world surrounding it. The World Health Organization, the Economic and Social Council of the UN, which passed the Declaration of Human Rights, which Lolita had kind of touched on before with the talk that we had before. And the Declaration of Human Rights basically says that access to medical care is a human right, and relief from pain and suffering is also a human right. So those two things together play into access to pain management. The United Nations Office on Drugs and Crime also puts out a World Drug Report every year that talks about diversion and abuse and trafficking of opioid medications and drugs. And the International Narcotics Control Board, which oversees the importation, exportation, and manufacture of opioids, puts out annual reports on the state of consumption, that is, how much countries are using the opioid medications and how much they're being produced and manufactured, how much opium poppy is being grown every year, et cetera. As well as special reports looking at different countries and the barriers to access that exist in those countries. So in 1995 and in 2007, the INCB actually did a survey to look at the barriers to availability, and they came up with these 8 barriers that seem to be common around the world. And I would even go as far as to say that most of these barriers all stem out of, number 1, fear of addiction. Because there's a fear of what addiction actually is and becoming addicted to these medications. The medications don't get stocked in countries, and when they're not stocked, then they can't be used to train students who are in medical school on how to prescribe them. And if students don't learn how to prescribe them, then as doctors they don't know how to prescribe them, and then they don't prescribe them. So you get lack of training, and you have these restrictive laws that don't let the country to import them or for hospitals to stock them. Doctors who aren't trained in how to use them are afraid of going to jail for prescribing improperly. In some countries, I think it might have been the Philippines, there actually was a law is a law on the books that says that you can actually be put to death for prescribing these drugs improperly. And so that, if I were a doctor, I wouldn't want to prescribe anything that might give me the death penalty. And then you get this insufficient supply, which boosts up the cost, even though they're very cheap drugs. Morphine can be about 1 cent or 2 cents per dose. I mean, it's very cheap, and so on and so forth. So all of these things kind of fall out and then affect access. So these are some of the programs that we work on. We do global and national evaluations of availability and accessibility. And this actually started with national evaluations that we did in the US and then have expanded. We've done a pilot evaluation in Latin America, and we're now working on a evaluation for a certain group of countries in Africa. We're hoping to eventually be able to do the whole world. So if you know anyone who wants to give us money to do that, send them my way. We also collect consumption data from the INCB and then manipulate it and put it on our website so that others can take it and create graphs and kind of distill information from it in a way that's a little easier than the rules that the INCB has. You'll see a few of the consumption graphs that I've made from our data throughout here, but you should go on our website and play. It's crazy the kind of stuff you can do with it. We've also taken part in the PAINS briefing series in the last year, which were a series of 6 briefs that we created on various topics dealing with opioids. And they were focused towards policymakers, and so we've sent those out to policymakers to kind of help them be more informed on how to effectively make policy in this area. We also offer technical assistance to any government that asks for it. We've helped countless countries in improving their opioid access. And then finally, the International Pain Policy Fellowship, which is what I'm going to be focusing on now. The IPPF is really the bulk of what we do. We've so far had 4 cohorts, and the first cohort was in 2006. We had one in 2008, 2012, and then our most recent one in 2014. Basically, it's a 2-year fellowship, aside from this last one, which was only a 1-year fellowship, to find folks in country who are passionate about this issue and who have the potential to make change in this area. And we give them a stipend to work for 8 hours a week on this and devote that time for 2 years towards trying to achieve a certain number of goals. So we initially bring everyone to Madison. We meet for 5 days. We teach them a little bit about the ins and outs of opioid access, the law, the barriers, strategies to overcome the barriers, and we help them come up with an action plan. They then take the action plan back to their country, and over the 2 years, we work with them to help implement that plan. At the 1-year mark, we have another meeting where we bring all the fellows back together, and we sit in a room much like this, and we talk about what obstacles there have been, where the action plan seems to be not succeeding, where we've had great success, and bounce ideas off of each other on what we can do to tailor the action plans, what objectives maybe aren't going to work out in 2 years, what objectives we could maybe add that have come up. And we've seen a lot of success actually at the end of the 2 years, and I'll tell you about a few of the stories kind of going forward, but it's pretty amazing what these folks can do with just 8 hours a week for 2 years. Our cohort in 2012 had a regional focus, a partially regional focus, in that we had several fellows from Bangladesh, India, and Sri Lanka. And then this last year, our 1-year fellowship was actually an African fellowship with fellows from 5 countries in Africa. So it kind of went over this a little bit already, but throughout the whole 2 years, there's a lot of back and forth that kind of happens with our fellows and with our office. We also have an international expert committee that works with our fellows, and they're usually folks who are not staff of PPSG. They're folks all over the world who have experience. Either they've been fellows in the past, we've had several fellows kind of graduate to the international expert committee, or they just have worked a lot in that area and they know the government, they know the society, they know the healthcare system, And so they're kind of a little more hands-on expert than, and they can fill in the gaps where we might not be able to. So just to give you an example here of some of the data that we have and how it relates here. So you can see here this gray bar, that's the United States, and that's how much opioid medications, how much opioids that we consume in the US in a year in 2012. So it's the actual number for the US is the morphine equivalence of opioid medication is 743 and a little change kilograms. You can see here that most of the other countries you can barely see them, and that's because most of them have less than 1 kilogram. For example, Nepal has 23 grams for the whole country. And the morphine equivalence, that metric is actually, they take into account all the different types of opioid medications. So, morphine, oxycodone, I would say Vicodin, but I think only the U.S. uses Vicodin, or it might be only oxycodone that the U.S. uses. But fentanyl, methadone, whatnot, we take all of that and we convert it to what it would be if it were morphine, that number of grams. And so that's the morphine equivalence. The ME minus methadone takes out methadone because methadone isn't always used for pain. It's more commonly used for drug therapy, as I'd mentioned. So when you take out methadone, a lot of the countries just disappear. And you can see that Kyrgyzstan and Vietnam, which aren't South Asia, but Asia nonetheless, those two countries actually almost completely disappear because most of their stock is used for drug treatment, since there are large issues with heroin addiction in those two countries. So moving on to some of our fellows. This is Vishnu. He is actually now a member of our International Expert Committee, and he's managed to actually bring morphine into the country. Before his work, it was very difficult to get it imported, and he's now been able to work with the Ministry of Health to get morphine syrup, immediate release, and sustained release tablets on the market. And then here again, you can see just comparing it to the global average, which is far less than what the U.S. average was. If you see, the ME equivalence is about 66 kilograms, and if you remember, the U.S. was at 743, so it's still just starkly different. So you can see that there's a difference there. So Madam Cham, she is another one of our fellows from Vietnam, and she also worked on getting the prescription validity extended, which is a big problem in a lot of countries. You'll have a prescription for, we'll say, morphine, and it's only good for the day that you get the prescription. You have to get it filled that day, and if you don't, then that's a problem. If you have a late appointment with your doctor and the pharmacy closes at 4 and there's only one pharmacy in the city, you have to come back to the doctor again. And if you live out of the city in a village somewhere, then that's a large problem, because it may be a huge undertaking to get into the city, to get to the doctor, and get to the pharmacy. And imagine if you have an end-stage cancer and you're trying to do all this. It's very difficult. And here again is Vietnam, and you can see again that the amount of opioid medications drops when you take out the methadone. Bangladesh, we had 2 fellows from Bangladesh, and they both did a lot of work on educating the policymakers and healthcare practitioners in Bangladesh on this issue. They also were able to start or help start in-country production of these medications, which then cuts out one issue of importing. So there's always licenses and regulations that go along with importing. So if you can create the medicine in your country, that cuts out one middleman and makes things a lot easier. And just kind of move forward here a little bit. Also Sri Lanka, we had fellows in 2012, and they worked on policy objectives. A lot of our fellows did work to create palliative care strategies, which are a common thing in countries. or cancer control strategies. Since cancer is actually one of the faster growing non-communicable diseases in the world, it's something that a lot of countries are putting a lot of attention to. And so they were able to work with folks in the ministry to put kind of a stress on treating cancer and palliative care for cancer patients into their strategy. So we'll move on to India, and this is going to be a little more in depth here because we've had a lot of work happen in India. We're lucky enough to have 3 fellows in India, and if you think about how big India is in comparison to Sri Lanka, we should have probably had 15 fellows from India. But these 3 fellows, Priya Kulkarni, Shalini Vallabhan, and Nandini Balan, the 3 of them worked very hard. India has had just obstacle after obstacle with opioid access in their country, a lot of it stemming back to British rule in India. And the biggest success that they had was something that PPSG has been working on since the 90s, to pass an amendment to the Narcotic Drugs and Psychotropic Substances Act, which is their law that controls narcotic drugs. So to tell you a little bit about that law. This law was passed in 1985, which was the absolute last year that a country could pass any legislation laying out the regulations and policies and procedures for dealing with opioid medications in accordance with the Single Convention. So they waited to the last minute, because if you think about it, the Single Convention was passed in 1961, and then this was passed in 1985. That's a very long time. A lot of the laws that they passed under this NDPS, the policies that were included in there all stem back to British rule of India. And just a little point of history with the British rule in India is that I don't know if you guys have studied opium wars and all that good stuff, but they made a lot of money from opium. And as a result, a lot of the laws that the NDPS put into place surrounding opioid medications went into the Department of Revenue and the Department of Excise, which doesn't make a whole lot of sense because they're medicines. So that meant that there were additional licenses required from those departments as well as the Ministry of Health. These licenses all needed to be valid at the same time, so you had to get one license from one department, turn around, send that to another department, get that license back, send that to another department, get that back. And each state had a different law on how this would work. So oftentimes what would happen is one license would expire before you'd get the next one, or one license from one state would expire before the one in the other state would be valid, and nothing would move, and so everyone would run out of opioid medications. Complicated. So the government of India kind of saw this as a problem. Our organization stepped in and said, let's work on this. We worked with some organizations in country, the Indian Association for Palliative Care, the Palliative Care Society, and we did a study on the regulatory aspects of the NDPS. And together we came up with the idea that why don't we come up with a simplified rule? We'll send it out to all the states. Each state could just adopt the simplified rule. Then everyone will be on the same page as to what needs to happen. It'll make things easier. We held workshops to help educate the different states on the modified rule. The INCB eventually endorsed it and said everyone should pass this. It'll make things easier. It'll improve access to opioid medication. It'll cut down on the suffering and pain of patients in India. And 18 states actually adopted the simplified rule. However, only one of them actually implemented it. So it really went nowhere. Even though all these states had it on the books, no one was doing anything with it. They weren't actually following it. They were still following the old laws that they had written that were ridiculously complex and needlessly cumbersome. In this time, a man named Ravi Gui actually filed a court case with the Supreme Court of India saying that his mother, who was a cancer patient and died without pain relief, was given, basically that she was given inadequate medical care. And he was suing that she should have had pain relief, and that since the medications weren't available in the country, that she was failed in this way. And this public interest litigation is actually still going till to today. It hasn't been resolved as of yet. There have been, it had been at a lower court, and they said, we agree with you, and kind of kicked it up to the Supreme Court to take a look at and decide on. And we're still waiting for them to come out with the dispensation on that case. So in 2012, they finally submitted a version of an amendment to the NDPS, to the Indian Parliament. And then a few palliative care organizations got involved, and they offered their thoughts to the amendments. And so the amendment, as it was presented to the Indian Parliament, was then created. A national palliative care strategy was created in November of 2012, and our fellows helped work on that. And that said that pain relief needs to be available, opioids need to be available for patients in India. And this all was looked at by the Department of Revenue, and they said, yes, this should be submitted. So it was then placed with the Parliament for a vote. And this is the closest that they had gotten to actually getting this amendment passed so far. So in February of 2013, it was placed on the docket along with, I think, like 180 other items, and only 20 items on the docket got taken up for discussion. This was not one of them. So we were told, okay, August, it'll be brought up in August. So August, again, monsoon session of Parliament, again put on the docket, never brought up for discussion. Then in December, it was put on the docket again, and again, not brought for another vote. And the issue here wasn't that people didn't like the bill. It was very well received within members of Parliament. Our fellows were diligently meeting with different members of Parliament and activists and celebrities and whoever they could talk to, news agencies, to try and get the word out about what they were trying to do. And most people said, this is great, let's do it. Not a problem, you have my vote. Problem is, they cared more about other things. So other things came up for a vote, and this just kind of sat by the wayside. So in February of 2014, well, going back to December, when that session closed, we thought it was done. So everyone started gearing our efforts towards getting the states to implement the simplified rules, to getting more states to adopt the simplified rules. We really thought that was going to have to be our focus, to try to do this one state at a time, and it was going to take a lot longer, and it was going to be a little more piecemeal, but we could get the same results just with a lot more work. Then we found out in February that they were going to open a special, I think it was a 2-day session of Parliament. And initially it was mentioned that this session of Parliament was to address matters of corruption within the government. So we thought, great, this is never going to get taken up. This is not what they're meeting about. This is not at all what they want to focus on. But then, last minute, it was the last item called, and it was passed. So it was passed in the Lok Sabha on February 20th, and then on the 21st, it was taken over to the upper house of the Parliament, the Rajya Sabha, and it was passed there. On March 7th, the President signed it, and on March 10th, it was published in the Indian Gazette and became formal law. So this did what the simplified rules were trying to do, and it told all of the states, this is exactly how all of you should deal with the licensing requirements for having opioid medications in your states. It took the list of essential narcotic drugs away from the states, and it gave that to the central government to manage. So now there's only one list of essential narcotic drugs instead of one for every single state. If the drug is at a recognized medical institution, then they can dispense opioids and they don't need any further licensing. And there's only one person in each state who's responsible for licensing now instead of 5 different departments or ministers. So really the whole process has become greatly streamlined. And going forward now, there's an issue of making sure that there's education done so that all the doctors get training on how to use these medications, because as I mentioned before, people who don't know how to use the medications won't prescribe them. Pharmacists won't dispense them if they're not comfortable with that. And also informing policymakers on these changes so that any rules that are made at the state level are still in accordance with the central government's rules, and making sure that the rollout of the medications actually happens well. In the 90s, when there was that renewed interest in promoting palliative care within India, there was actually a kilogram, I believe, of morphine imported into the country, and it was thought, great, if we just bring this in and just give it out to the hospitals, problem solved. What happened is that doctors didn't prescribe it because they didn't know that it was there, they didn't know how to use it, they were afraid of using it, and so the stocks all just expired on the shelves, and it was useless. So now comes the work to combat that and to make sure that everyone who needs it is able to get access to adequate pain relief. So if anyone has questions, I am happy to answer questions. I know that was probably a lot of information just kind of placed in your lap. So
thank you very much.
Yeah.